All right,
Okay.
good afternoon, everyone, and welcome to the South Texas Regional Family Medicine Grand Rounds. Our department mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Next slide, please. Let's see. Is it going?
Sorry, I think it's loading.
It's okay. All right, there we go. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaged in the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session evaluation form. Next slide, please. The Family Medicine Grand Rounds for September 6, 2023. The activity code is 10093-213. To get that CME credit, you need to make sure you text attend and then the following number 10093-213. Next slide, please. The new CME credit system, like I mentioned before, you need to text this following number to 844-502-1338. And again, the activity code for September 6th is 10093-213. Next slide, please. CME transcripts. These are the steps to access your transcript from all along School of Medicine CME activities. You can visit the following website and the information is there. Next slide, please. The American Academy of Family Physicians, AAFP members, you can claim this activity for AAFP credit at the following website. Next slide, please. The Family and Community Medicine Grand Rounds address nationally established physician core competencies. You can see the following below. I'll leave the screen up for a moment so you can read them. Wait, next slide, please. The conflict of interest statement. So Jem Alegre, MD, and Carmella DeSerto, MD, have no financial relationships with ineligible companies to disclose. Next slide. And I'm going to hand this off to Dr. Nato to introduce our two residents that are presenting today. Thank you.
So thank you. So we're continuing our series of poems, and today it's Relapse of Depression, presented by Dr. Jem Alegre and Dr. Carmella DeSerto. The faculty member for the session is Dr. Yun Shi. And so I really appreciate it if you would give them your attention, and then we'll have perhaps an interesting discussion after we hear the prepared remarks. Thank you.
All right, thank you for that introduction, Dr. Nato. Good afternoon, everyone. Today, so we're going to discuss relapse of depression, and right here, these are our objectives. We're going to review the SSRI monotherapy, so that this is what that study was, and I'm going to mention those SSRIs later. We're also going to identify the characteristics of patients that are considering discontinuation of SSRI therapy or antidepressant. And finally, hoping for some discussions in the end, as well as this is discussions with the patient, risks and benefits of discontinuation their depression monotherapy. Next slide, please. So again, this poem is about relapse of depression, more likely after discontinuation of medication based on the study done by Lewis G. et al. From the New England Journal of Medicine. It was published in New England Journal of Medicine, September 30, 2021. It was maintenance or discontinuation of antidepressants in primary care. Just a side note, this study, which I'll mention again later, was done in the UK. Next slide, please. Oh no. this is not the sorry, that's not the updated slide, but it's okay. So we're gonna talk through it. So a little bit of the background. The primary objective of the study is to conduct a randomized, double-blind, focusing on patients in primary care settings that are on long-term antidepressants. As we know, we're taking more and more care of patients are taking over their antidepressants versus psychiatry. And just a note, this was an old study, and they projected that more and more primary care physicians will be prescribing antidepressants, and their prediction was right. Their study, the researchers, no, you can stay in that slide, sorry. So the researchers conducted the Antler trial, which the same authors did, and hoped that their study would provide more guidance and improvement in recommendation of long-term therapy of antidepressants in primary care. Compared to what previous other trials have done, they failed to do those trials with timing of the study not long enough, or power of the study. They just didn't have enough participants to draw a firm conclusion. In addition, the Antler trial, what I added simply was it was an antidepressant trial that they did, and that's their acronym for it. In addition, what the authors hope to the outcome of the Antler trial is to refine our understanding of the costs and benefits of long-term maintenance. They provided two different scenarios. First, if their trial shows that long-term maintenance therapy is ineffective, then that will decrease unnecessary therapy that would also decrease patient exposure to adverse events and lower the cost of medicines if we don't need to put our patients in antidepressants. Second, if the trial proves to be effective, then the patients who are not currently taking medications to prevent relapse might benefit from antidepressant use. Okay, next slide. So this is the methods and design. I'll talk more in detail. This is just an outline of a quick outline of what they did. So they recruited about a total of 478 patients from 150 general practices in the UK. To be eligible, patients had to meet specific criteria, a history of at least 2 depressive episodes, or taking antidepressants for 2 years or longer. The antidepressants they focused on were the SSRI, that's citalopram 20 milligrams, sertraline 100 milligrams, fluoxetine 20 milligrams, or mirtazapine 30 milligrams. I know you guys are thinking right away, mirtazapine is not an SSRI, but they decided to add it in their study because there was an increased use of mirtazapine in the UK population. Mirtazapine is a noradrenergic. It has more of a noradrenergic mechanism to it, but overall, it still kind of acted the same way like an SSRI would. One of the antidepressants, one of the SSRIs that are not here was paroxetine, and the reason for that is it has a short half-life, and which means that if the patient was on long-term paroxetine and we stop it, you could just picture that patient will go into relapse pretty quickly. Then these patients, so continuing on, these patients were randomly assigned to one of 2 groups, the maintenance group or the discontinuation group. And I just wanted to clarify that the discontinuation group meant that they were receiving placebo. So it wasn't just like they were monitoring them not taking anything, but as a measure, they used the placebo. There were 2 outcomes. So the primary outcome would measure the first relapse of depression during a 52-week trial period. So this was a year trial, and which had checkpoints at 12, 26, 39, and 52 weeks. Then participant characteristics, still on this slide. Before getting to the results, let's take a look at who the participants were. So 73% of the patients were women with an average age of 54 years, plus or minus 13 years. 238 patients were in the maintenance group, while the other 240 were in the discontinuation group. Next slide, please. in this slide, it's a very summarized slide of the outcome of the primary outcome. In the maintenance group, they observed a relapse rate of 39%. In contrast, the discontinuation group had a significantly higher relapse rate of 56%. The hazard ratio, as you can see there, is a 2.06 confidence interval, likewise, with a significant, that's clinically significant of p less than 0.001. And the number needed to harm was 6. So one may argue that for those that want to look at the glass half full, or the ones that are kind of like more, let's take away some medication, positive outlook on this would be, you can argue that 44% of the patients that discontinued the medication did not have relapse. And this is something to think about when a patient comes in and wants to discuss about discontinuing. But we'll get to that discussion a little bit more later. Next slide, please. So the secondary outcome, in summary, mirrored the primary outcome. These measured the screening things that we use already in our FHC-RBG of PHQ-9, 0 to 27, higher number, which means increasing severity of depressive symptoms, and then GAD-7, 0 to 21, with higher number correlating to uncontrolled anxiety. Quality of life was measured based on a mini survey of 12 questionnaire based on their physical and mental health well-being. It was scored from 0 to 100. Higher scores equals better quality of life. The table you see on your right hand is a little busy, but to summarize it, the patients in the discontinuation group experienced more symptoms of depression, anxiety, and withdrawal than those in the maintenance group. What's important to note here is that one of the SSRIs that was excluded, like I mentioned, was the paroxetine due to short half-life and withdrawal risks were higher, is not here on this table. The table is just providing the checkpoints that I talked about earlier, which is at 12, 26, 39, and 52nd week. For the secondary outcome, however, the authors did mention that since they didn't have a pre-specific plan for the adjustment of the confidence interval for multiple comparisons, no definitive conclusions can be drawn from this data that were found, unlike the significant clinical finding from the primary outcome. Finally, adherence to the trial regimen was also monitored. And it's worth noting that the adherence to the assigned treatment, SSRI versus placebo, was higher in the maintenance group, with 70% adhering to the medications compared to the 52% in the discontinuation group. In addition, those patients that were on the discontinuation group, 39% of them actually restarted their antidepressant therapy. All right, next slide, please. Then they disclosed their adverse events. So here we see that 4% on maintenance had serious adverse effects, while 3% in the discontinuation. Something to ponder that although the trend has been showing lower chances of relapse in the maintenance group, for those that are leaning more towards, again, discontinuation to lower the risk of adverse events, there was a slightly higher percentage, which was 4% of the 238 participants versus the 3% in the discontinuation group. But overall, the trial, whilst having serious adverse events, fortunately, there were no deaths or suicidal attempts during the trial. Next slide, please. So, in conclusion, the study found that among primary care patients who felt well enough to discontinue their antidepressant therapy and those assigned to stop their antidepressant medication had a significantly higher risk of relapse by 52 weeks compared to those who continued their current therapy. So these findings have important implications for the treatment of depression in primary care. However, there are limitations. For example, the study needs to have more diverse patient demographics. Just to give some specific numbers, again, about 75% were women. The average age was just 54, with a long gap, like plus or minus 13, and 95% were white. This does not really match our patient population, and that personalized treatment plan may be necessary to optimize patient outcome. Next slide, please. All right. So again, the discontinuation led to higher relapse of depression with increased severity of depression and anxiety. There's a greater likelihood of resuming antidepressants, 39% of the discontinuation group to go back to the antidepressant therapy. And again, it provides insights into maintenance versus discontinuation. In the end, their studies supported the importance of continued therapy in primary care. Next slide, please. I talked about this, sorry. And next slide. So moving forward, what does this mean for us? On that study, I say we need to individualize the therapy. For example, in that study, they didn't mention any support of BHC, where they having psychotherapy, where they combine therapy with CBT, which is evidence-based of the combination of the two for higher success rate of controlling depression. Their focus was solely mainly on just the antidepressants alone. So that's something to think about. And even though this was a 1-year trial, maybe longer term, like longer than the 52 weeks. Next slide. Oh, sorry. And then, right, so this is what I talked about, like having behavioral health consultants part of their care, which I talked about. And in the end, it becomes like a collaborative decision-making between us and the patients. Finally, next slide. So just to the summary of points from the objective, we reviewed the dose of the limitation. Here I said the limitation of the study reviewed, but included in the poem, I found that on the Antler trial. It wasn't on this journal, so just a correction, they did show the dosage, but I had to go to a different source. We identified the characteristics of patients to consider discontinuation of SSRI therapy. So they have to be ready, they have to feel ready to discontinue. And like I said, you have to discuss with your patients about the risks and benefits. And with this 52-week trial, it hopes to give us some guidance on how we feel or what to present to patients if they want to discontinue, and you have a mutual decision in doing that. That's it. Next slide. And these are my references. Any questions before I hand it over to Carmella?
Yeah, I have a couple of questions. So let me make sure I understand it correctly. So these are patients that their depression's improved, and then you're deciding whether and so they're on like maintenance therapy, which has changed over time, over my career. So you treat them, and then at some point you'd stop them. But now the trend is to leave them on maintenance for longer. And so this study actually gives credence to the idea that you should keep them on maintenance for a long time. So I'm just trying to, so in terms of taking this to practice, to our practice, I think that gives us support for leaving somebody on maintenance, but I'm just trying to figure out how long, right? So 2 years, 5 years, 10 years. You treat somebody when they're 40, should they still be on it when they're 75? So I think that gives us a lot of questions.
Yes, excellent point, which is what I brought up on the limitation study. This was only a 52-week trial. which is a little bit more success in the previous trial. I agree with you that we need, we need it to be longer, and that was the limitation. And the second part of that question was like, do we take them out? Again, it's a very limited study. This was like strictly just focusing on antidepressants alone, SSRI. There weren't really any cognitive behavioral therapy. I would imagine that if they were in combination therapy, not monotherapy, just with medication, maybe that would increase your leaning towards discontinuing, and maybe they're not going to get into relapse if they know how to manage their depression with cognitive behavioral therapy, again, which was unfortunately not really mentioned in the study.
Thank you. Before I yield the floor to Dr. Fortune, the other thing that struck me was, it would be helpful if they could sort out, by doses, right? With the people on the higher doses, is that better? Is that worse? In terms of how they fleshed out, and then specifically by each drug. And I know that study probably doesn't have that level of granularity, but I think ultimately that would be nice to know.
Yes. Just to note, the dosage that they used were the ones that the patients were controlled under. So there's like a 20 milligram, and sertraline was 100 milligrams, I believe. But yeah, so that's another limitation of the dosage. Yes, Dr. Fortune.
Jim, I have a quick question.
Okay.
For the discontinuation group, did they taper medication over time?
Yes,
Was there
they did.
abrupt? Okay.
No, excellent question. Yes, they did. It wasn't shown in their review, but if you look at the Antler trial, they were tapered for at least like 6 weeks before putting into the placebo, and that's why they screened it starting at 12 weeks of the relapse. More in detail about the safetiness of their study were mentioned on the adverse events.
Thank you.
This is Dave Cotterdahl. Can you guys hear me?
Yes.
I just wanted to make a comment. So in response to Dr. Nato's issue, the studies in the US have suggested that if you take people off, people who've been well maintained on antidepressants, about a third of people will immediately relapse, about a third of people can go off and won't relapse at all, and about a third of people will relapse after a short period of time, like a couple of years. And every time they relapse, their chance of a future relapse goes up. So if you take somebody off, they relapse, you put them back on, they respond, you take them off again, they're going to relapse at a higher rate. And so the conventional wisdom has been, after a couple of relapses, you never take them off, you leave them on. The other thing I wanted to mention is that in the UK, they don't subscribe to the DSM system. And so anytime you're looking at a psychiatric study, you need to ask what are the criteria they're using for the diagnosis, because they're not using DSM criteria.
Thank you. Dr. Fortune, go ahead.
Dr. K kind of took a little bit of my thunder there, but yeah, I would say that this study is more of an argument to take people off of antidepressants, to give them a chance to not relapse, just because, based on this study, a little less than half of patients are going to be able to no longer take that medication. And then, other studies have shown about a third. So if you can get at least a third of your patients off of the medication, then I think that this would be an argument that you should at least do a trial to reduce it with, as long as you discuss with them the risk and benefits, to rapidly taper it back up if they have a relapse.
There's a question on the chat. The question was, did they include in the selection criteria any history of relapse in the past? No, they did not. And in terms of the severity of the MDD, they were, per their criteria, these people were they were controlled in depression. They didn't have like active depressive symptoms. Dr. She, no, the other question by Dr. She's like, are recurrent MDD patients? No, they were excluded. These again are, I believe that they were like controlled for like 2 years. This study like had 20 something thousand initially screened and then just kept going down, and the final number was 438. And in addition to Dr. Katterdall's comment about the DSM criteria, yes, it was different in a way. They did mention that. So the criteria for their MDD was they would have been at least like one mandatory was they must have had depressive symptoms for 2 weeks, at least 2 weeks, and then only one of like the depressive symptoms, just like sad thoughts, suicidal ideation, guilty feelings, like Siggy caps that we use here. So it was really, it's different criteria, like what Dr. Katterdall pointed out. Any other questions? Dr. Fortune, is your hand still up or no? Okay. All right, well, thank you for your questions and your attention. So I will now pass it on to Carmella, Dr. DeSerto.
All right. In continuation of a similar theme, we're going to move from a poems about maintenance versus discontinuation of monotherapy to selection of combination antidepressant therapy, what clinical situations you might do so, and what medications you might choose. The objectives for this presentation will be first to identify which clinical presentations are appropriate for combination antidepressant therapy. Specifically, we're going to talk about what combination therapy, and then we'll select the appropriate combination based on that clinical indication. And then at the very end, we'll review other options for evidence-based adjunctive antidepressant therapy in contrast to combination antidepressants. This poems was called Combination Antidepressant Therapy is More Effective Than Monotherapy for Acute Severe Depression and Non-Responsive Depression. And it was based on the JAMA article Combining Antidepressants versus Antidepressant Monotherapy for Treatment of Patients with Acute Depression, a systematic review and meta-analysis from February 2022. Background here. So our current guidelines recommend our initial treatment for severe depression as being a single non-monoamine oxidase inhibitor. So that could be an SSRI, which most people will pick as the initial therapy, an SNRI, or a TCA antidepressant. Also, response to initial therapy is usually 60%, and remission is only 40%, even after 12 to 24 weeks of treatment for most people. So what that means is 60% of patients that you start on monotherapy will have response, but only 40% of people will experience remission after 12 to 24 weeks. And then typically our second step of that treatment is, do we switch the initial choice of medication? Do we increase the dose of the initial medication chosen? Do we augment with a different medication? Or do we combine with a different antidepressant that also fits these categories? So that's the difference between what we'll talk about being augmentation versus combination. This article focuses on combination. So choosing an SSRI, SNRI, or TCA, and also another one of that category. So doubling up, essentially, instead of picking something like an atypical antipsychotic or lithium, or one of that would be adjunctive therapy, which we'll talk about at the end. The methodology for this meta-analysis was looking at a lot of randomized controlled trials. Those randomized controlled trials had to analyze monotherapy versus combination of 2 antidepressants. The patient population was either first line for acute severe depression or treatment-resistant depression. So those were our 2 patient pools. And then the primary outcome of this study was treatment efficacy using standardized mean differences. As a note, I didn't talk about it in this presentation, but they also had several secondary outcomes. Most notably was tolerability. So when looking at the comparison between monotherapy and combined antidepressant therapy, how did people tolerate it? And though I don't have it in the slide, the result was that it was essentially the same. There were 39 total trials included, with a patient population of 6,751, and the studies ranged in publication date from 1977 to 2020. Patients had to be adults and they had to be diagnosed with major depression. And then they did have exclusion criteria. Studies that only focused on bipolar depression were excluded, and studies that just looked at maintenance therapy were excluded. So it had to be a comparison study. The results were that when comparing monotherapy versus combined antidepressants, combination therapy was superior in efficacy. And similar results, so superior efficacy for combination therapy also resulted when they restricted the studies only to those that they identified as having low bias risk, which was 15 of the 39 studies. Interestingly, when they specifically looked at bupropion as the drug of choice for combination, it was not superior for efficacy for the people who had first line severe depression, but it was superior for treatment resistant. So that was the only specific medication that was different, in that it only worked superiorly for the treatment resistant people. Discussion and application. So how does this kind of summarize and then apply to our practice at the Family Health Center? So first, I think the biggest difference here is most people are going to pick monotherapy as their first line. The first thing they do, they diagnose somebody with major depression, they start them on one drug of choice. And maybe our next step in practice is often, do I pick combination therapy or do I pick adjunctive therapy after this insufficient initial monotherapy response? I'd like to underline here that this study showed that combination, so the addition of another medication, is potentially more efficacious, so better, more effective than increasing the dose. And they actually cited 2 other meta-analyses that looked at that idea. Do you switch? Do you increase the dose, or do you do combination therapy? Do you add a medication? And switching the drug of choice and increasing the drug of choice was not more effective than just sticking out the initial choice. So something to consider when thinking about what is my next step in this process. Those meta-analyses, which we won't discuss in detail, showed that switching and increasing actually was not more effective, which I thought was really interesting. I think it's important to note that combination therapy was not associated with more dropouts in the study, and it was not associated with more adverse events. So from a safety outcomes perspective, we're looking at similar results. And then some of the trials were showing that there was a favorable outcome when the second added antidepressant was at a subtherapeutic dose. So choosing an initial SSRI, let's say, and then adding on another one, but at a lower dose that you would not typically think of as therapeutic, was showing a synergistic effect. And they went into the pathophysiology in the meta-analysis, which I don't think we need to get into too much detail of here. But that's something to consider. You know, do I add something on at a lower dose to try to mitigate some of those worries about adverse and side effects? Limitations of this meta-analysis. So number one, there was substantial heterogeneity of effects of the randomized control designs. So I didn't put it in this presentation because it was real nitty-gritty details, but they ended up doing many different statistical analyses to control for different effects. So low bias versus high bias, how heterogeneous the study was. And they did all of these different models, and they ended up coming up with essentially the same results no matter what they applied. So that was controlled for. Possible reporting bias. So what that means is, by the nature of the randomized control studies, there's no placebo, right? They're looking at monotherapy with a drug versus combination therapy with drugs. So there's no placebo, so there's no negative, there's no null here. This study did adjust for possible bias, like I said, and when they took out anything they thought might have a higher risk of bias, they still had the same results, though I will mention it was a reduced efficacy. So like it was still more efficacious, but it was at a lower percentage. It was still statistically significant though. And then there was between study heterogeneity, different control groups and different studies of treatment-resistant depression versus the acute severe, two very different patient populations. But then the study writers also talked about how, regardless of whether you were looking at continuing your initial dose, increasing that dose, or switching monotherapy, no matter what you did with monotherapy, combination therapy was better. So in summary, what do you do? What do you choose? The combination that we're talking about is either an SSRI, SNRI, or TCA antidepressant, plus your combo here is an alpha-2 adrenergic receptor antagonist. So that's either mirtazapine or trazodone. That combination is what we studied, and that combination is more effective than monotherapy. So you could think about picking something like sertraline plus trazodone. And you could pick that trazodone at a subtherapeutic dose if you strongly wanted to avoid adverse effects, and it was still more effective. Other conclusions, this applied to patients when choosing their first line initial choice if they fit the criteria for acute severe depression, or in patients who were just not responding to monotherapy. This was your step up. And it showed that it was easy to tolerate in the secondary outcomes, and that there was that synergistic effect even at subtherapeutic doses. So what do we do in clinic? How could we apply this to our practice? This is an alternative choice that you can make based on this data for these two patient populations. If you initially start someone on sertraline and they don't respond, you can consider adding mirtazapine or trazodone. You could do that for anything that kind of falls in an SSRI, SNRI, or TCA. I think that's very patient picture dependent, right? What are their other comorbidities? Are they struggling with sleep? Are they struggling with weight, underweight, overweight? What does that look like? And then making the choice between adding a new antidepressant, mirtazapine or trazodone, or, and this is where I'll put in a plug for adjunctive therapy, do I go down this route that we're talking about in this paper, or do I go down adding something else that's not in that category? And we won't go into too much detail about the evidence behind adjunct choice, but that's of course varied based on clinical picture as well. Many different options, many different studies. You can go into a deeper dive about this, but things like atypical antipsychotics, so quetiapine, or Abilify, lithium, anti-seizure medications, thyroid hormone, depending on the clinical picture, buspirone, estrogen for postmenopausal women, and then not something I see very often, but also in the literature, methylphenidate. Those are my references, and I'll take any questions or comments.
This is Dave Cotterdahl. I have a couple comments. First of all, I think we've known for a long time trazodone is not much of an antidepressant. It's a very weak antidepressant. One thing mirtazapine and trazodone have in common is they're both sedating. And depending on how their measure of response was taken, if they were just using some sort of a scale, some sort of an instrument, well, you would expect adding mirtazapine and trazodone is going to improve their sleep. And so if that's part of the depression scale, yes, that's going to get better and it's going to look like they responded better. But in fact, all you're doing is helping their sleep. And so that's potentially misleading. The second issue I wanted to raise is when you're initially starting somebody on an antidepressant, it must be a sufficient dose. It must be a truly antidepressant dose before you can say it's failed that dose. So when I was in psychotropic clinic, it was not uncommon for people to be referred as a treatment failure when they had never gotten off a subtherapeutic dose of the antidepressant they were started on. It's fine to start a subtherapeutic dose in a patient if you're worried about side effects, they're elderly, whatever, but you can't rule them as a treatment failure until they've had an adequate trial of a sufficient dose. And so that's been a problem in the past.
Thank you. Yes, I think those points are both important clinically and for safety of our patients, right? This information applies only if someone has had an adequate trial and really truly failed. And then, yes, so to add to Dr. Catterdahl's point, the measurement tool that they used in the meta-analysis was the Hamilton Depression Scale, the Hamilton Depression Rating Scale, which is a lot like when we use SIGI caps, but just a detailed version of it. So if those points are in sleep and fatigue, then yes, that will skew your data if that's the only thing that's improved. They didn't necessarily go into detail about what in the depression rating scale was improved.
Hey, this is Palacios. I just have a question. I know they didn't get into much of the what augmentation is, because that can probably get very complicated. But did they make any mention as to why they're calling this combination therapy and not augmentation therapy?
They didn't comment on why they chose that as the definition, but yes, those are the verbiage they used was combination therapy to describe SSRI, SNRI, or TCA plus mirtazapine or trazodone.
Generally in the past, psychiatry has used the term augmentation as to include drugs that are not antidepressants, but that help antidepressants to work better.
So yeah, because I was confused on like the terminology. So what would be the difference in augmentation and adjunctive therapy? Like,
yeah. So augmentation and adjunct are using interchangeably. This study is specifying two things that are considered antidepressants.
Okay, so based on if they're typically indicated for depression or not.
Yeah, so if you, for example, use sertraline and quetiapine as your combination, that in this study wouldn't be combination therapy, that would be adjunctive therapy.
And adjunctive or augment
Same
words.
thing.
Cool, thanks.
Dr. Nato, you have your hand up.
Sorry, I thought it was interesting that that we had the SSRI, SNRI, and the TCAs, and sort of we're kind of comparing those groups, but side effect profile wise, those are a lot different, right? So I think to me, the TCAs are excellent antidepressants, probably equal in terms of efficacy if you can get them to what's considered therapeutic doses. But I think it's easier to sort of quit before you get there because you have trouble getting there, and you add another medicine to it. Maybe that doesn't necessarily help the side effect profile. Maybe that increases it. But so I think it's hard to see those exactly comparable since the side effect profile is so different, at least in my hands.
Yeah, I think that's an excellent comment. The study grouped those three as the choices because of the pathophysiology of the reuptake as non-monoamine oxidase reuptake mechanisms. And so I think if I were to look at the detail of all 39 trials that they picked, probably included more trials for a reason. But yeah, if you're going to pick a TCA, for example, the clinical picture probably needs to necessitate that. If you're just dealing with first-line acute severe depression, I think most people are going to probably lean towards an SSRI as their choice, plus or minus if you're going to choose to do this combination versus adjunctive therapy.
Yeah, I mean, I have a lot of, I mean, I think that TCAs are great drugs. I think they're especially good for migraine prophylaxis because they tend to be effective at lower doses than what you need for depression. So not to badmouth them, but just to kind of put that as perspective.
Yes. Dr. Shi, you have your hand up.
Yeah, sorry, Carmella, you mentioned it earlier. I missed it. What did you say about the bupropion?
Oh,
I
yes. So
forgot the point.
bupropion. Yeah. So bupropion in the meta-analysis for patients who were first-line acute severe depression, it was not superior to do bupropion as part of the combination therapy. But if they were treatment-resistant depression, if they fit that patient population, then it was superior as well.
Okay, half of the population included in this one. Okay, thank you.
Any other questions, comments? I think ultimately, to summarize what we do in the Family Health Center, I don't know how much this data is going to change the way that I practice, because ultimately I think that second decision that you make is very clinically relevant based on their clinical picture. Does the person, like Dr. Nato said, suffer from migraines, or is their sleep poor? Or do they have some other reason to be on one of the dozens of choices of what you could pick as that second medication? Dr. Sabir, you have your hand up.
Yes, and this isn't directly for you, Dr. DeSerto, but for all the faculty that might be here, when do we then know like to use combination versus augmentation if someone has treatment-resistant depression?
Well, since I have my hands up, I'm going to try to answer it. Everyone can correct me. So I think in our practice, at least we don't have a lot of evidence for the combination therapy as of yet. So what has been tried and true has been, augmentation from all the evidence we have known. But a lot of times in practice, I've noticed that we prescribe trazodone or tazepine, especially these two for other complaints, right? Weight loss, appetite issues, sleep, without knowing that maybe have a synergistic effect on, the depression symptom. I think we might have done it accidentally. Although I think when we were prescribing them on its own, usually they require higher doses to have antidepressant properties versus if we're treating them for insomnia and poor appetite. So I think in this study, they did say lower doses alone, they have synergistic effect on the first line antidepressants they're on. So I think it's fair to try both, whichever fit in better safety profile and med adherence, less side effects. I think, Marion, I think it's either or, individualized. I would be interested to see in comparison the combination versus augmentation, which one would be more efficacious and better safety profile.
That makes sense.
Thank
Thank you.
Any other questions or comments or sage advice?
All right, if we don't have anything else, just a reminder to complete the evaluation. The QR code is on the screen. Also in the chat, I placed the URL there. So thank you so much, Dr. DeSerto and Dr. Alegre. And with that, we'll end grand rounds and we have teams at 1:30. Thank you.